Good evening. I'm Lisa Burke from the Department of Rural Health at the University of Melbourne. I'd like to begin by acknowledging the traditional owners of the lands from which this webinar is recorded from and streamed to. I pay my respects to elders of these many nations, past and present, whose cultures and customs have nurtured and continue to nurture these lands. I also acknowledge and pay my respects to all Aboriginal and Torres Strait Islander people joining us this evening. And I acknowledge that these lands are unceded despite being home to the oldest living cultures on the planet. Myself, I'm here on beautiful Yorta Yorta country on the banks of the Goulburn River in Shepparton. And I know many of you come to this meeting from Kulin country, Wadawurrung country, and other traditional nations. Throughout tonight's webinar, there's a Q&A icon at the bottom of the screen that you can use to ask questions. We'll try to get through as many of these at the end, and we've also got some questions people provided us when they registered. But tonight, the University of Melbourne Department of Rural Health is very excited to bring you a webinar by Professor Dave Coghill. Dave is the Financial Markets Foundation Chair of Developmental Mental Health at the Departments of Paediatrics and Psychiatry at the University of Melbourne, and also Professor of Child and Adolescent Psychiatry at the Royal Children's Hospital in Melbourne. Dave's research focuses on increasing understanding of child and adolescent mental health, and recently Dave co-published a paper on ADHD medication for children and adolescents. Professor Coghill advocates for children and adolescents with ADHD, a lifelong condition for many people, that if untreated can result in serious negative outcomes. ADHD is known to affect 7% of children and 2% of adults worldwide. So we have much to learn. So tonight, please welcome Dave Coghill to speak with us on understanding ADHD. Why is Philip such a fidget and Johnny an airhead? Thanks, Dave.
Thank you very much, Lisa, for such a kind introduction. If just somebody lets me know that my screen is now sharing, I will go off on our story. Thank you very much. And so hopefully you all came because the title was so enthralling. Fidgety Phil and Head in the Hair Johnny, understanding ADHD. I'm going to come soon to who Fidgety Phil and Head in the Air Johnny are, and they're an important part of my story. Not only do I have my academic credentials and clinical credentials that Lisa mentioned, I've also just taken over as president of the Australian ADHD Professionals Association. I have some disclosures to make. I have worked with several companies that make medications for treating ADHD and other conditions. I also receive royalties from Cambridge and Oxford University presses. So ADHD, what is it? Well, at the very most basic level, ADHD is about a group of 3 different types of symptoms: hyperactivity and impulsivity, which we tend actually to talk about together because they do tend to co-occur very much. And then inattention is the third of the group. But the symptoms of ADHD on their own are not enough to diagnose ADHD. And this is hugely important. Lisa mentioned the prevalence of ADHD, how common ADHD is. Actually, ADHD would be an awful lot more common if we didn't have these other criteria that we need to meet before making a diagnosis. And this is one of the reasons why what has come to be called a TikTok diagnosis or a checklist diagnosis is something that really we can't work with. Because in order for these symptoms to count as ADHD, they need to be persistent over time. They need to be pervasive across at least 2 different settings. For children, that's often school and at home. For adults, work and home. But also, we look socially. They should have been present from relatively early in life. Before the age of 12 is the technical definition here. And most importantly, they need to be causing significant impairment to someone's day-to-day life. If we didn't have these criteria, then, for example, for children, around 25%, 1/4 of all children would meet the symptom criteria for ADHD. As it is, I slightly take lower numbers than you heard before, and I'll show you around 5% of children meet these much more rigorous diagnostic criteria. ADHD is also, as you'll hear, associated with a lot of coexisting difficulties. It rarely occurs on its own. This is who Fidgety Phil is. And I talk about Fidgety Phil to really reinforce the fact that ADHD, although we've heard about it a lot more in the past few years, is not a new construct. It's not a new concept. This is the story of Fidgety Phil, as you see, from Dr. Heinrich Hoffmann, a pediatrician in Germany in 1845. If you've ever get the chance to read Dr. Hoffmann's book called Strumpfelpeter, Shock-Haired Peter, which has a number of, I guess, what we could call nursery rhymes, many of them rather morbid nursery rhymes, about children with different types of mental health problems, or what we would now know as mental health problems. Fidgety Phil was one of them. And here illustrated by Fidgety Phil at the family dining table, in the end, unable to sit still, pulling everything over him. And there's a particularly morbid version of this last picture with knives and blood and all sorts of horrific consequences from Philip's hyperactivity and impulsivity. And then there's Johnny Head in the Air. Johnny Head in the Air is in the same book. He's not as often talked about. Fidgety Phil has become a bit of a poster boy for ADHD talks. Johnny Head in the Air gets a bit forgotten, but no less important. And as you'll see, Johnny trudged to school, walking along, watching the clouds, not paying attention to what was going before him, and then ended up drowning in the canal. And since this time, since the mid-1800s, there's actually been several repeated sightings of ADHD, both in the medical and non-medical literatures. As we already heard several times, ADHD is common. 5 to 7% of children and adolescents, and I think around 2.5% of adults, about half that in children. It's more common, at least during childhood, in males than females. It's more common in children than adolescents. And as you see, it's more common in children and adolescents than it is in adults. That means that some people grow out of ADHD, but not everyone. A lot of people continue to have ADHD. A little bit harder to interpret that slide at the bottom about the geographic location. But thankfully, our colleague Guilherme Palanchik from Brazil, who did this work, and it's really the pivotal work in understanding how common ADHD is, realized when they looked at studies that actually, if you take out the methodological differences, if you take out the differences in the way that ADHD was measured across different studies, then ADHD is just as common in each country that has been looked in. And so ADHD is one of the few disorders that has an equal presentation in Asia, North America, Africa, Oceania, etc. And if we take these figures together, that means that around 800,000 Australians have ADHD. Now, this is a little technical, this slide, but believe me that we go from 1985 across to 2010. And what this slide is very clearly telling us, from epidemiological studies, from studies that look at the population rather than at the rate of diagnosis, that ADHD prevalence, how common is ADHD, is not increasing over time. What's increasing over time is the recognition of ADHD. And I'll come back to that and its relevance in Australia in a few slides. So ADHD is just as common now, and actually there's data that extends from 2010 to much more recently, which suggests that, again, there has been no increase in how common ADHD is. But ADHD is not this common. You'll notice in this map of the United States that only one state, Nevada, has a rate of diagnosis of ADHD that's equal to or less than what we call the prevalence of ADHD. So for me, it's actually very clear that in many parts of the United States, particularly those on the eastern side of the country and what's called the Midwest, are over-diagnosing ADHD, because these aren't rates of how common ADHD is. These are rates of how common is ADHD diagnosed and treated. And this has been a problem for us in the field, because people assume that just because ADHD is being overdiagnosed in America, it's being overdiagnosed everywhere else in the world, including Australia. But actually, we have quite good data to show that this isn't the case. If you look down the right-hand side here, this is talking about how much ADHD is being treated in different age groups across Australia. And this is very recent data, just published at the end of last year in the Australian and New Zealand Journal of Psychiatry. What it does show is that there, between 2013 and 2020, there was a twofold increase in the prevalence of ADHD treatment, of medication use. And that increased from 4.9 to 9.7 per thousand, meaning about 0.5 to 1% of all people. But of course, the rates were very different depending on ages. Very low in the under fives. Thankfully, I would say, we shouldn't be treating ADHD routinely in those under 5 years of age. That doesn't mean people under 5 don't have ADHD, but ADHD is very difficult to make a definitive diagnosis on below the age of 5. And that should really only be considered in extreme cases. And then between 6 and 12, a big jump, 6%. Between 13 and 17, 4.5%. This is the percentage of people being treated. But then when we start to get to adulthood, drops down to 1.5% and 0.4% for those over 25 years. My understanding of this data would say that actually in Australia now, we're doing a reasonable job of picking up and treating children with ADHD and adolescents with ADHD, although we're not at this point over-diagnosing. However, when it comes to young adults and adults, actually where the bulk of the cases are, because much broader range of ages, we're still very much under-diagnosing. So although there have been increases, and although those increases have been bigger in females than males, we're still very much under-recognizing ADHD. Why is ADHD important? Well, it's important because it has a huge impact on the people with ADHD and also their families. It has a social, academic impact. an impact on their interpersonal relationships, there's a family burden, and on people's self-worth. Let's unpack that a little bit. The impact of ADHD changes over time. We start off with mostly the behavioral disturbance, but then during the primary school age, we start to see the academic impairments, poor social interaction, poor peer relationships, and what we call comorbidity, other problems, other disorders like anxiety, like depression, start to come in. As we move into adolescence, we still see the academic and social interactions. We start to see more of an impact on low self-esteem, increases in smoking, alcohol and drug use, increases in antisocial behavior, and different patterns of comorbidity. When you get to college age, these are American slides, but when you get to university or college age, young adults, again, continuing academic failure, not coping well with daily tasks. Why do we see this more then? Because, of course, the support of the family is much more distant when people are starting to individuate and often live away from home. Occupational difficulties, low self-esteem, alcohol and substance misuse, and a real increase in injury and accidents. And then into adulthood, I'm going to expand on this a bit more. So I won't focus on it just now, but let's just move on, because these are some of the adult outcomes of ADHD when it's untreated. And if you look at that left column, what it says is people with ADHD receive much less in the way of an education. Understandably from that, they also have much less opportunity and positive experience in the work environment. Because of that, they have money difficulties. They have difficulty saving. They have difficulty paying bills. They also have difficulty with driving. Driving offences and accidents are much higher in those with ADHD. They have many more lifetime moves of residence and far fewer peer relationships, close friends, more social problems, and more interpersonal and sexual difficulties. One of the things that's not on here is a hugely increased rate of teenage pregnancy. And if you've got poor education attainment, you've got poor employment prospects, you've got little money, you can't drive because you're banned, you've got instability as far as your living circumstances go, your peer relationships, you don't have great interpersonal and close personal relationships. What do? You spend more time watching the TV. And add to this high rates of crime, high rates of substance misuse, and high rates of psychiatric disorder. And I just want to show one more statistic that I actually find both shocking and really, it really sticks with me. This talks about two things. First, this is about ADHD increasing your risk of dying. But also, it talks about the problems of our poor recognition of ADHD during childhood and the consequences of that, because those whose ADHD is not diagnosed until over the age of 18 have much higher, in fact, 4 times higher rates of dying than those whose ADHD is diagnosed earlier, but also much more, 4 times more than people without ADHD, but also more than 2, almost 3 times higher rates than those who get diagnosed and treated during childhood or adolescence. That's a really big issue. We also see similar figures when we look at the rates of suicide. Rates of suicide in those with ADHD are 10 times higher than the rates of those without ADHD. But these deaths here aren't due to suicide, they're due to accidents. They're due to being pedestrians and walking out into the road, or more commonly, being a driver of a car that leads to an early death. So these are, I think, really quite shocking figures that tell us how important ADHD is. If you want to look at it from another perspective, from the cost of ADHD, we identified that the total financial costs of ADHD were over 12 billion, almost $13 billion a year. And then there were loss of well-being, which was just over $7.5 billion. So when you add this together, the total cost of ADHD is over $20 billion a year. And what we know, and I'll talk a bit about treating ADHD, is that if we treat ADHD, we can reduce these costs significantly. However, in order to treat ADHD, we're going to need to be better at recognizing it, and actually also about destigmatizing the having ADHD, because that's something that keeps people away from treatment. This is a very brief part of the talk, and I'll show you why in a second. But what causes ADHD? It would be lovely if I could give you a simple answer, but there is no simple answer. ADHD has a number of pathways to these symptoms, and these include genetic, environmental, brain differences in the way in which the brain develops, and differences in the way in which the brain handles information. And none of these pathways are independent or more prevalent than one other. So I leave that there just really to summarize that genetics are very important. ADHD is highly heritable. It runs in families. The genetics, however, are complex, and we are never going to find the gene for ADHD because there is no one gene. But that doesn't mean environmental factors aren't important. They interact with genes, and they're probably more important actually at affecting the course of ADHD rather than actually causing it in the first place. There are differences in the brain's structure and function and development between people with and without ADHD, but these are also very variable, and you cannot and probably will never be able to accurately diagnose ADHD through the use of brain scans. Similarly, there are many cognitive difficulties associated with ADHD. These include things like planning, working memory. People often talk about executive functioning. But importantly, none of these cognitive processing difficulties are present in all people with ADHD. And the cognitive patterns, just like the genes, just like the brain structure and function, are really variable between different people with ADHD. And this is the reason why cognitive tests cannot be used to diagnose ADHD. Much of the rest of what I'm going to talk to you about is based on this Australian evidence-based guideline for ADHD. This was published actually towards the end of last year. It says July 2022. It went public in October 2022. There's a link there, and we're going to get that link put into the chat so that you can go to it. And also, many of you might be interested in this, which is the Consumer Companion Guide to this evidence-based guideline. This was just published last week, and again is available. Both of these are available free online from ADPA, the Australian ADHD Professionals Association. So I flag those up for you if you want to do some extra reading. What does the guideline mean for you? Well, we developed it in order to improve the lives of people with ADHD, but in order for it to be worthwhile, we need people to adopt it and implement it. And one of the things that's going to help adoption and implementation is empowering the community of people with ADHD, their families and other interested parties to be putting pressure on me and my clinical colleagues. And so the consumer companion is really to help make sure people are fully informed when being diagnosed, treated and supported. Highlights from the guideline include recommendations about identifying ADHD, assessing and diagnosing ADHD, education and information about ADHD, and treatment of ADHD. I'm just going to run through some of these briefly, and we can discuss them more in questions if you have questions. But one of the things the guideline highlights is how important it is for clinicians, me and my clinical colleagues, to think broader about who might have ADHD and to focus on those that are within high-risk groups. Who is this? Well, children in out-of-home care, children diagnosed with oppositional and defiant disorder, with conduct disorder, with anxiety disorders, with epilepsy or substance misuse. For adults, adults with any mental health disorder. This is a real kind of crusade that we're going on to get my adult psychiatry colleagues, whenever they see someone with a mental health problem, to be asking, not is it ADHD, but could ADHD be part of this presentation, particularly those who are experiencing suicidal behaviors or ideation. Those with other neurodevelopmental disorders, such as autism, intellectual disability, tic disorders, language disorders, those who are born preterm, those with a family member with ADHD, those who were unfortunate to be prenatally, before birth, exposed to substances, including alcohol and other drugs, those with acquired brain injury, people in prison and the justice system, people of low birth weight, and, as I said before, people with other mental health problems. One group that the guideline really highlighted is women and girls with ADHD, because we might not be fantastic at recognizing ADHD in boys, but we're a darn sight better at doing it in boys than we are in girls and women. Girls and women with ADHD are less likely to be referred for assessment, more likely to have undiagnosed ADHD, and unfortunately more likely to receive an incorrect diagnosis of another mental health or neurodevelopmental disorder, such as anxiety or depression, when actually a diagnosis of ADHD, either instead of or as well as these other diagnoses, would be more appropriate. Why? Why does this happen? Because the typical picture of ADHD we have is that occurs in males rather than in girls. Girls with ADHD tend not to stand out so much. They tend not to be as oppositional, as present as many behavioral challenges. And they can be the person who really drifts into the background in class, not getting on with their work, not succeeding academically, but not challenging the teacher. When we think about assessing for ADHD, to be diagnosed with ADHD, a person needs to be assessed by a trained and credentialed clinician, such as a pediatrician, psychiatrist or psychologist or nurse that's registered with the Australian Health Practitioner Regulation Agency, APRA, and who has been trained in diagnostic assessments and be experienced in the area of ADHD. And this second bit's a bit of a stumbling block for clinicians, because actually training in ADHD has not been a core part of training for pediatricians, psychiatrists, or psychologists. And that's something we're really fighting for, is to say that ADHD should be a core part of what these professionals do in their education. Diagnosis should also be by interview. Questionnaires are not enough on their own. And that accounts for two situations. Clinicians should not be using questionnaires to diagnose, but also you can't diagnose ADHD by doing questionnaires on the internet. And that's something that people have kind of been socialized into, sometimes by TikTok, sometimes by websites that claim, come and do your ADHD assessment here. Why? Well, the checklists are good at picking up the symptoms, but they're not good at those other things that I said were important, like, is this impairing? Is it impairing across different situations? Has it been present since early on, etc.? Cognitive testing and expensive neuropsychological testing is not a requirement for assessment. I get many patients tell me that that's what they've been told by their doctor, that they need to have these expensive assessments. While cognitive assessments can help us understand the person and understand their strengths and weaknesses, and can be very helpful in putting together a package of treatment, they are never diagnostic. Why are they never diagnostic? Because, as I said, the cognitive profiles, the strengths and weaknesses of people with ADHD are so highly variable that there is no one cognitive profile. And so that's a really important message to give. The message is not that cognitive testing is not valuable, but that it's not diagnostic and it's not required to make a diagnosis. Also important is that assessment should not just be about ADHD, but should be comprehensive and include assessment for common co-occurring conditions and what we call differential diagnoses, other explanations for things that look like ADHD. When you've had a diagnosis, really the first part of any treatment package is what we call psychoeducation. It's a key component of managing ADHD. But as I've said here, not done well. And here I put up some questions that you could use to ask your clinician. You may like to take a photo of this, but what I meant to say at the beginning is I will make all of these, excuse me, all of these slides available. So you can stop and read these at your will. But these are very fair questions to ask a clinician when you've had a diagnosis of ADHD. And a very important part of learning about ADHD and a really key first step to treatment. When it comes to treating ADHD, and I'm getting towards the end of my presentation, we have medication treatments and non-medication treatments. And the trick is to bring these together in what we call a multimodal package of treatment. The aims of treating ADHD are not just about reducing symptoms. As I've said here, they're about improving understanding about ADHD and its treatment. That's psychoeducation. They are about reducing core ADHD symptoms, the irritability, the impulsivity, the hyperactivity, and the inattention. Also, reducing, I would hope, optimizing associated symptoms, especially the one that we call emotional lability, high emotionality, flaring from 0 to 100 at the slightest provocation. That's something that's very common. We don't call it a core symptom of ADHD, but it's very, very common in ADHD. To reduce coexisting disorders, and then of course to improve functioning and quality of life at home, at school, in the community. And then to do all of these things without causing harm. Medications are the most effective way to reduce ADHD symptoms. I'm not going to talk too much about any of these treatments in detail. I can answer questions on them if you'd like, but there are basically two kinds of medication. Stimulants, this includes methylphenidate, often known as Ritalin or Concerta, dexamphetamine, and lisdexamphetamines, brand name is Vyvanse. And the non-stimulants, guanfacine, or known as Intuniv, or atomoxetine, again known as Strattera. Of these medications, the stimulants are the ones that are the most effective and that work much more quickly than the non-stimulants. They are actually amongst the most effective medications in the whole of medicine. And they're therefore usually the first recommended medication treatment. 7 out of every 10 people respond well to each of the stimulants, and at least 90% respond to at least one. But it's not possible to predict who will respond to what and what dose. So we still need to use trial and error when we're treating ADHD. That's unfortunate, but it's a fact. And anyone who tells you otherwise, unfortunately, is not telling you the whole truth. We also know, and Lisa mentioned, I published some work on this recently, that these are safe medications, not just in the short term, but we have data now to support their safety in the longer term, and that they do not lead to drug misuse. In fact, treatment with these ADHD medications, including the stimulants, reduces rather than increases rates of substance misuse. The non-medication approaches, on the other hand, are much less effective at reducing core ADHD symptoms, but they can assist greatly with skill development and improve a person with ADHD's well-being, quality of life, self-esteem, social, adaptive, and family functioning. So it's not a competition between the medications and non-medications. It's actually about them both having different targets. The approaches include lifestyle changes, parent and family training, and cognitive and behavioral intervention. The lifestyle changes, I call them simple things. They're often not simple, but things like changing sleep patterns, diet, engaging in physical activity, all impact on health and well-being, and do so in people with ADHD. They don't reduce ADHD symptoms, but they improve the lives of people with ADHD. And our guidelines say that people with ADHD should be offered guidance guidance on, or a referral to a specialist who's qualified to assist with improving sleep, diet, or physical activity, if required. Parent and family training. This includes a broad range of different approaches that all aim to help parents meet the additional needs of children and adolescents with ADHD. I'll come back to that in a minute. But to be effective, what they need to do is support optimal parenting skills. It's challenging, whoever you are, to parent a child with ADHD. They need to focus on strengths and challenges and be delivered in sensitive and culturally appropriate manner. And they need to do this in a balanced way. And they can include education and information on ADHD symptoms and their impact, so an extension of the psychoeducation, recommendations about modifying the environment, and strategies to modify behavior, including positive parenting approaches. Important to note, though, that the offer of parent and family training does not imply that one's parenting skills are deficient in any way. It's that specific skill development is helpful for supporting children with ADHD. That's a really important message again. And lastly, just to talk about cognitive behavioral interventions. These are delivered directly to the person with ADHD. They use, again, ways to improve education and impact, but also therapeutic interventions that help people process thoughts, feelings, and facilitate skill development in a range of different ways. These are specialist and skilled interventions, and there are new ones coming online all the time. Recently heard about a great new, not idea, but process that's coming from the US, using what they call motivational interviewing with parents and teens. So it's actually a combination of cognitive, behavioral, and parenting approaches. And also, these can have a great role in addressing co-occurring conditions like anxiety and depression. Just want to mention ADHD coaching. There's not much evidence around about ADHD coaching, but those of us that have engaged with ADHD coaches have really found their work to be helpful with our patients. And so the clinical guideline group and the guideline itself actually says people should think or could think about coaches, and there are some very good ADHD coaches across Australia. When you're planning treatment, really, and I think this should be obvious now, you need to think about multimodal treatment. You need to put these pharmacological, non-pharmacological, educational, and coaching approaches together into a package. Thinking about which treatment will be most effective in which aspect, without overwhelming someone with maybe introducing everything at once. We have a famous saying about medicines that pills don't make skills, and it's true. But often treating with a medication first can help put someone in a position where they can make more use of other types of supports. And so in summary, this is my final slide, I want to say that, second final slide, I want to say that ADHD is a common, complex neurodevelopmental disorder affecting a large number, almost 1 million Australians. There's a really very significant impact on individual lives and costs over $20 billion a year in our country. It's currently under-recognized and under-treated, particularly in girls, women, and adults. Assessing ADHD is a skilled task, cannot be conducted through questionnaires and videos, and treatments for ADHD are, when delivered properly, very effective. There are, however, currently significant issues facing those with ADHD in Australia, particularly with access to treatment. And for this reason, really support the fact that the Senate has initiated an inquiry into ADHD to address a wide range of issues about services and their accessibility. The response is quite soon, June the 9th, and I urge everyone to consider making a representation. The details are here, and I hope this is going into your into the chat or the Q&A so that you can think about making a submission if you're interested. So thank you very much indeed. I know I've run a bit over, Lisa. I haven't looked, and people have probably been telling me, shut up, shut up. But I think I wanted to try and give that rounded story. So thank you for your indulgence, and thank you guys for listening. I hope that's been helpful to you.
Thanks so much, Dave. That was terrific, really insightful. Great to hear from the expert, and I think great to hear it in language that us non-medicos really understand. I've got some questions here. If you don't mind, I can just ask some of the questions that have come in. So what sort of things would you suggest a teacher might do or adapt in their classroom to support children in the class that might have ADHD?
Yeah, I think that's a really, really important question. It differs at different stages during schooling. The one I get asked about most at the moment is at the end of schooling, when people are doing their VCE, etc. And can people get extra time on tests and extra support? And certainly that's something that is important. It's actually quite difficult to navigate, and we're currently in argument a bit with the education department to say it's good to give people quiet spaces, it's good to give people breaks, but actually they need extra time. But when you're in the classroom, if you're a teacher managing a class with children with ADHD, one of the important things not to do is to put them at the back. Another important thing is not to put them all together. But if you sit them at the front, if you give them written instructions as well as verbal instructions, quite often kids find it helpful. And I like the fact that almost every school in Australia has an oval. Kids get out a class card, where when things just get too much, they can actually go out, run around the oval, use up some of that energy and come back. All these things are quite helpful. And if you are a teacher, then actually there are some great bits of advice on the internet. It's one of the areas where the advice is good. One of the things teachers say to me, though, is it's not fair. I can't put all this time to the child with ADHD when everyone else suffers. And I can't provide special sort of treats and support for the child with ADHD. And one of the answers to that is that get everyone on board, get everyone supporting that child with ADHD. So if the child with ADHD does well, does better, reward the whole class. And so the whole class knows that if they support, then actually everyone gets something from it. So I think there are a whole range of ways. I'm not pretending it's easy, and there's a lot more work needs to be done. But the simple things actually often do work.
Yeah, okay, great. And what about for parents and siblings and, in the home environment? What sort of things can help support young people?
So for parents of children with ADHD, understanding that a child with ADHD often can't do it to the level that you would expect by their age and their intelligence, rather than won't do it. And so actually taking into account that ADHD does mean that children with ADHD have delays in being able to achieve particular tasks, and therefore they require more scaffolding. So the kids with ADHD that do well because of the understanding of people around them, because they're not always expected to act their age or behave their age, but they're scaffolding and rewarded for doing the best that they can. And again, just rewards always work better than punishments. And how can I reward one child and not the other? Well, reward them all. And again, get them to support each other. It's that same thing. But again, the specific parent management programs are designed to try and help people learn the tips and tricks. They're again not things that you can do boom, boom, boom at the end of a lecture. They're things that take time. And so understanding that it's not being suggested that you do this work as a punishment or a criticism of your parenting. It's a recognition, this is a bloody difficult task. It's hard to help. And, you know, you need to have extra skills and extra support.
Yeah. Okay. And we've got some questions coming in. So Jasmine has asked about the relationship between childhood trauma and ADHD. Is it common?
It's a great question. The answer, Jasmine, is yes, it's very common, but the direction of relationship is often not what people think. It's often about trauma and ADHD rather than trauma or ADHD. So we now have a lot of research which shows us that children, in fact, people with ADHD are much more likely to suffer a wide range of traumas compared to people without ADHD. And that includes traumas such as sexual abuse, physical abuse, neglect. And so it's usually not a discussion about whether this is trauma or ADHD, but how the ADHD and trauma are related. And there's some interesting work that shows that trauma itself increases ADHD symptoms, but rarely tips someone over into the diagnostic category. So if you meet the diagnostic criteria for ADHD, it's very likely that you have ADHD. Now, nothing's certain, but also that treating the ADHD can help people manage the experience of trauma. And we've shown recently, even with sexual abuse, that children with ADHD who are treated are less likely to be sexually abused than children with ADHD that isn't treated. And that's actually not just about who gets treated, that's within the individual child. And so it's a really fascinating question. But what I would urge you, Jasmine, is not to get caught into the, is it this or is it this, but to think about the possibility that it's both.
Okay. And Craig's asked about, are there any benefits in medicating suspected ADHD and then sort of based on the response to the medication, you know, deciding around?
That's a really sneaky question, Craig, and a difficult one. The straight answer is no. People without ADHD respond to those medications in the same way as people with ADHD, to a degree. So all of us would be able to focus and concentrate better. So treating ADHD, looking at the reaction, isn't a way to decide whether or not someone has ADHD. But more controversially, we're realizing now that some people who don't quite meet the diagnostic criteria for ADHD, and usually that's they haven't got quite enough symptoms, but they do have impairments, actually have as many difficulties as people with ADHD. And so that's going to throw up the question for us in the future. And if we treated those people with what we're calling subsyndromal ADHD, would we improve their lives? And would that be the right thing to do? That's not an answer that says, yes, we should be. That's saying that's a real question that we don't have an answer to yet. So at the moment, I would answer quite definitely no to Craig's question. You need a diagnosis, you need an assessment, and you get that before you get treated. But it's not quite black and white like that.
Okay, thanks for that very considered response. Kara's asked if is it common for Johnny the airhead to exist without symptoms in the other categories?
Yeah,
And
another great question. Tamara, was it?
Cara?
Cara, sorry, Cara. It's an important question, Cara, and I didn't go into that. It's very rare to get hyperactive impulsive ADHD without concentration problems, but it's actually relatively common to get Johnny head in the air, inattentive type ADHD without the hyperactivity and impulsivity. It's said to be more common in girls than in boys, but it certainly occurs in boys as well, not infrequently. And likewise, there are many girls who have full-blown, what we call combined ADHD, and not just the inattentive bit. But yes, you can get inattentive ADHD without hyperactivity and impulsivity. And interestingly, it responds to treatment exactly the same as the combined full-blown ADHD. So our treatment of those people is exactly the same as our treatment of people with the full-blown ADHD.
Okay. And Danielle here has asked, talking about Danielle's 13-year-old son who's been diagnosed with ADHD, but Danielle's son has never accepted the diagnosis and refuses any help. Is this part of the symptoms? And what can be done to support teenagers to adjust?
That's another great question. It's not really part of the symptoms, Danielle, but it is part of being 13. And there are many teenagers who, at least initially, reject their ADHD, and it's really challenging. Part of that psychoeducation that I say isn't always done well by healthcare professionals is to try to work with those feelings and that understanding. And I guess it's try to break through with the young person who's not accepting, to try and understand what is it about the diagnosis that's difficult to accept. Are there things that that person does accept aren't going well? If not, then one needs to keep chipping away. And one of the things that I've often had to do is sometimes with young people immediately after diagnosis, but very often with adolescents who've been in treatment and then suddenly decide, no, I don't want this anymore, I don't like it, is to make sure that we keep the door open. And so one of the problems that I've seen is that health services push people to discharge you if you're not taking medication, for example. We've always tried to resist that and just to keep that door open, to keep that conversation going. And almost always people will come back and either accept treatment or, start to accept the fact that there's an issue. I don't know your 13-year-old, so I can't be any more specific than that. But I think persistence and an open door, an accepting attitude is something that people need to have.
Okay, thanks for that contribution. Emma's asked about workplace accommodations for adults with ADHD, particularly adults who appear to be performing well on the surface but are struggling with organisation, time management. They may have a lot of anxiety about their competency, but colleagues and managers sort of think they're doing okay.
Yeah.
Any suggestions for those workplaces?
Lots of suggestions, but most of them come off the top of my head rather than any evidence. It's an area that people haven't done a lot of good work in. Many of the same things that we would be advising for schools would be appropriate for the workplace. And the people who do this stuff best are the ADHD coaches. And many of them are starting to move into that more corporate field as well to help workplaces. So I think I just came back, well, a month or so ago from New Zealand, and there's the BNZ, the Bank of New Zealand, has taken a really positive attitude, not just to neurodiversity, but to ADHD in particular, and have started to put in those accommodations and supports. So I think being understanding and helpful, and as I said, $12 million of the cost to Australia is in productivity. So I was fortunate enough to be speaking with Minister Shorten yesterday about the kind of things that we should be looking at. And my view, this is controversial at times, is that I'm not asking for ADHD to be considered as one of the list diagnoses for NDIS, but that in areas like employment support and accommodation, that's where NDIS can play a big part in helping not just the individual, but helping the organizations, the corporate organizations, to actually become more friendly. And I asked a question, a rather, I haven't actually looked to see whether it was answered, a question to some people in the sort of more autism neurodiversity space, to ask them if it's possible to actually make neurodiversity about neurodiversity and not just about autism. Because actually often when we talk about neurodiversity, it's shorthand for talking about autism. But of course, ADHD is a part of that neurodiverse spectrum of issues. And it would be great if the people who are putting all of their energies into making workplaces more accommodating for neurodiversity would consider ADHD. Now, you can call me cynical or mischievous or whatever, but I think it is an issue that, you know, often ADHD isn't considered seriously enough as something that impairs. But again, Minister Shorten yesterday was, you know, really keen to hear more. And I hope that we can work with him and with other people in Parliament to actually get employment as one of the things that that is looked at.
Okay. We've run a little bit over, so some people might need to go, but I'll just ask you one more question. Because I think there is a lot of interest in this topic. And Jo has asked, she's suggesting that as a community, we're doing quite well to destigmatise autism. How do we achieve this with ADHD?
Okay, well, I would say as a community, Joan, we're doing much better with ADHD than we were when I came to Australia 7 years ago. And I don't take credit for that. But with few exceptions, we're actually now getting much more positive stories in the press than we were before. We've got a Senate inquiry into ADHD that I think is going to help. We've published some papers on stigmatization and ADHD, which think about ways forward. My colleague Lou Brown, if people want to have a look at the ADPA website, you've got a couple of links to it there for the guidelines, but Lou has also published a guide to speaking about ADHD. So getting our language right when we talk about ADHD. And I think all of these things can help. She also recently put together, and I think it's published, I think it's on the ADPA website, a little guide on how to tell your story about having ADHD, so to help people tell a positive story. And so I think you're right to really focus on this, Joan. I don't think we're doing a bad job at changing attitudes. We've got a long way to go, and people like you, hopefully people like everyone who's been listening today, can really help us with that message.
Mm. Well, thank you so much, Dave, for sharing your wonderful insights, for directing us to a range of resources to help us all become more informed and answer our questions. And yeah, thanks for putting it in terms that I think we've all been able to understand and learn from. So I really appreciate you.
Can I thank you and the school for inviting me, and for everyone for coming. Thank you so much.
Yeah. And I'd like to thank everyone for coming. For those who put forward questions, always good to hear your queries and dilemmas. Di will be sending out an email with the slides from tonight, which contain a lot of resources and areas for us all to seek out more information. So thanks Dave, thanks to everybody, and have a great evening.
Thank you.